So we think this topic of payment reform is very important for European countries because we suspect that economic growth across the Union is going to be slow at best over the next 5 to 10 years, and that because healthcare takes such a large proportion of public spending, much more thinking, radical thinking has got to take place as to how to extract more value out of healthcare. Now, there is a number of ways that policymakers can do that, but one of the levers is in fact the currency with which providers are paid for the care that they offer, and that if governments or payers can be smarter in designing those currencies, then perhaps that can help to extract more value, more quality of care for people out of the. So that's why we particularly focused on. And this is fundamentally important because unless we can extract more value, then the risk is that the solidarity of our health systems, that is the way we extend it to most people in the population, if not all, could be under threat unless we can extract more value for the money that we spend upon it. Well, what we've learned today is that most countries across Europe are experimenting with different forms of payment currency for providers. That there are two main dimensions of this currency. One is the extent to which payments are bundled for providers. The other is the extent to which there is a pay-for-performance add-on to the bundling, and we know that across for payments for institutions, that is hospitals, it's mostly now the DRG payment, which is a prospective payment system, and countries are thinking about the pay-for-performance add-on for quality. And for physicians, the usual method of payment is some combination of a capitated payment with a fee-for-service add-on, or indeed a salary with some kind of performance add-on. And those at the moment are the two sort of prevalent sort of types of payment. But what we're now seeing is, because we're all facing this huge challenge arising from older, frailer population needing to think about much more about the cost effectiveness of care for these individuals and quality, and that many more countries are now considering really more innovative forms of payment, bundling across pathways, that means across settings according to where patients are treated, and thinking much more carefully about the quality that they are paying for. So paying for more where there is extra quality, or withholding payment where there is less quality. So the discussion today really sort of went along those two dimensions. And I think what we discovered was that there is huge complexity in both dimensions. It is not as simple as those two dimensions set out, and that there's no magic bullet for payers to institute. The other important message was that payers can't, it's important that payers don't actually feel that they have to micromanage providers through ever more complicated pay-for-performance or payment currencies, that actually there is a moment to step back and let local providers decide what the quality measures are over and above some basic level that is set by the payers. And then if there are key priority areas that the payers feel the quality is not being forthcoming in providers, then to go in more detail with those particular areas. To develop these more sophisticated form of transmural payment currencies really demands a lot of management time. It demands a lot of time to develop and investment to develop the information systems required, and to have constant calibration, which at the moment is annual and probably may need to be more than annual, to make sure that providers don't get used to these and maybe even need to be stretched further. So it's a complex message, but I think we were all rather sobered by the fact that although this is a very complicated area, we don't have much time in some countries to make the changes, and therefore we're really going to have to accelerate and be bold and be more radical. And then the other part here is that the researchers also have to step up to the plate in developing more rapid forms of feedback on the impact of some of these changes. You just simply can't wait now for 3 years for a full-blown evaluation to take place. So there are data requirements needed, there's more timely information required, and there's much more analysis and thought to be given to the evaluators of these interventions to see what the impact is for policymakers who have to make decisions here and now, because unless they can, then there's going to be some pretty drastic cuts having to be made across health systems, which is not going to please the population. So there's no alternative but to think about these things more creatively.